This is going to be interesting coming after the last discussion, because we're just going to sort of leap somewhere else, and the big question, I suppose, is going to be on everyone's mind is the ability of the American public to somehow, I think, beyond their borders, to think of people whom we don't see all the time, but we hear about. You know, prior to this administration coming in, we probably had one of the biggest and the greatest, I suppose, steps taken towards addressing global health that has happened in years, and that was what is considered one of the main legacies of President George Bush, which was his proposal and his funding of treatment of people with HIV. We know that, you know, millions of people, we had known for some time, 33 million people now are infected with HIV. And President Bush, I suppose, as a way of sort of counterbalancing our policy in Iraq, proposed that we provide up to $15 billion over the 5 years from 2003 on to the treatment of people with HIV in about 15 countries. Some $25 billion later, you have to imagine that at the time that this was proposed, we were talking about hundreds of millions of dollars of going to HIV and AIDS, not much more than that. Now we're up to, you know, to an administration that is proposing $9.6 billion for a series of programs, the main one being HIV and AIDS under the initiative started by President George Bush, which is the President's Emergency Plan for AIDS Relief. It now is part of an umbrella group of programs called the Global Health Initiative. President Obama has said he's going to start changing the way we do business. It's clear we're coming up against some notion of the finite, and the question is how we're going to the problems have grown even with the funding. So the question is going to be how we're going to deal with, I suppose, problems that we had not begun to define as well when President Bush, you know, proposed the President's Emergency Plan for AIDS Relief. So I'm going to start with Dr. Anthony Fauci, who was a part of that group that met in the administration of President George Bush to sort of create the President's Emergency Plan for AIDS Relief. What did we learn from that? We're now up to 33 million people infected with HIV. What are the lessons that have come out of that? And, you know, can we continue, I suppose, treating people? I think that we are now up to about 4 million people in Africa and around the world being treated, even though it's understood that maybe 3 times as many need treatment.
Well, there are several things that were learned by that experience and by the actual implementation of that truly transforming program. And that is that you should not assume, the way some people did early on, that you cannot deliver rather complicated health care implementation to people in the developing world, namely getting them to get tested and get drugs that you have to take virtually every single day. So it was not only a proof of concept, but it was actually something that had been implemented very well. And the numbers are really extraordinary. The PEPFAR program is responsible right now for about 2.5 million people who are on therapy, close to 1 million babies that were saved by the blocking of mother-to-child transmission. 10 million people who are under care, including AIDS orphans. So it really is one of the truly landmark programs that the United States government has implemented. That's the really very good news. The sobering news is that when you deal with such an enormous problem such as this, and AIDS is a classic prototypic example of that, but as I'm sure you'll hear from Tim about malaria and then tuberculosis and others, is that the solution to the problem is just not treating people. You've got to treat the people who are infected, but if you look at the totality of people in the low and middle income countries, 30 to 40% of the people who need therapy are getting it, which means that 60 to 70% of those who need it are not. For every one person that we put on therapy, 2 to 3 people get newly infected. So if you just do simple math, the number of new infections are outstripping our capability of not only initiating therapy on newly infected people, but even sustaining the therapy in the people. It's economically not feasible. We need to try as best as we can. The answer and what we've really learned is you've got to prevent HIV infection. I mean, that's the thing we need to do. We have well-proven, biologically proven modalities of prevention, ranging from condom distribution to mother-to-child transmission, to circumcision, to needle exchange, to a variety of things. That's the good news. The sobering news of that is that only 20% of the people who would benefit from those preventive modalities actually have access to them. So the lessons we've learned is that when you're dealing with a disease like that, prevention is a major part of what you need to do. And also, you've got to get the countries themselves involved in making these types of things part of their own programs. And I think that's what the Global Health Initiative is trying to do, not only by having a larger umbrella of which PEPFAR is a part, and maternal health and child health, etc., but making it a part of development where countries have an investment in the health of their citizens, as opposed to the United States and other developed countries coming in and continually taking care of them. So an amazing amount has been accomplished, but there have been, as you alluded to, Brenda, some very important lessons that have been learned. So I'll stop there because I'm sure we'll have questions about that.
Okay, I'll try to make this not just about money, but, and we'll come back to this question of whether by changing the approach, strengthening health systems in these countries, whether in fact you can do these things more effectively with the resources that you have, the limited resources that you have. But before we go into that, as I noted in the beginning, we started out talking about 300 million or so a decade ago, and now we're up to about 25 billion, with this administration proposing 48 billion over the next, I guess it's actually 63 billion with all of the programs included over the next 60 years. But then you've got a whole bunch of groups. You've got a lot of other folks involved here. You've got the Bill and Melinda Gates Foundation. We've seen a lot of actors coming in. The U.S. is the largest contributor, but it contributes 40%. But then there are all the other folks, and you've got people saying, what we really need is not $40 billion, which is about what the total amount of contributions are right now, but we need probably about twice that amount. You've got lots of different people with their hand out for one thing or the other, and I don't want to say handout. That's probably not a fair description. I'll allow Laurie to kind of put that into some sort of perspective for us. What is Japan, the United Kingdom, along with Bill and Melinda Gates, what is being asked of all of the players, and what is everybody doing, and what can we expect them to do? Why is it, the U.S. is not doing this alone, let's put it that way.
One of the things that we all know here in the United States from our own experience is that health costs money. That you can have all the goodwill in the world, but unless there's cash to purchase the necessities for cleaning up water supplies and distributing pills and bed nets to prevent malaria infection, you can't accomplish very much with just good intentions and Albert Schweitzer-like zeal. The good news is that between 1998 and 2008, the total pile of cash out there for what we grandly call global health increased exponentially and went from somewhere in the ballpark, depending on whose numbers you're using, between $400 and $500 million. That's for everything that we call health, from clean water supplies all the way to pills being handed out and training doctors and all sorts of things. And we are now well into the ballpark of 45 to 50 billion if you include all the range of things that I put in the original number. The biggest driver of that increase, without a doubt, has been the United States government. And if you actually combine private and public giving from the United States for this whole pot of global health. We are by far the biggest donor. I mean, in the scale of 60 to 70% of the cash that's out there for what we call global health. And so this puts us at a difficult moment in light of the rest of the discussions that you've heard today. General Odierno said, you cannot succeed in this new vision of Iraq, or by implication in what he was saying, and where we're going with Afghanistan, if you can't increase the level of the civilian engagement in what we're dealing with in foreign assistance. You have to, that means you need a strong U.S. Agency for International Development, a strong global health initiative, and a strong Account 150, to put it in budget terms. But we're in a different world now as of the elections, and we're in a very different world from the one in which Tony Fauci played a pivotal role in the creation, the conceptualization of this thing we call PEPFAR that Brenda was describing. I mean, that was the post-9/11 world, and it was a world in which there was an awakening among Christians at a very grassroots level across the United States to the need to engage as Christians in improving the health and the lot of the lives of people outside the United States. And so you had literally from grassroots churches a kind of a movement in the United States that supported President Bush's very surprising announcement. I mean, I think Tony was one of a handful that knew what he was going to say when he stood up at the State of the Union address and announced, by the way, I'm going to throw billions of dollars at the HIV/AIDS epidemic. And now where we are, when we look at the constant nudging the U.S. government is giving to the rest of the donor community to step up to the plate and collectively at least combine all of them to match what we give. If we could just accomplish that, we'd have a hell of a pot to fight for global health with. Look at where we are now. First of all, we have an enormous wealth gap that has occurred, that was already in process of occurring before the 2008 financial crisis. Just here in the United States in 2005, the bottom 50% of our population earned 12% of the wealth of our country, while the top 10% earned 21%. But according to the 2009 census, that got much worse, so that the bottom are about 3.4% and the top 41.5%. That sort of widening of the gap of wealth and shrinking of the real income of middle classes is not a uniquely American problem. In fact, the most extraordinary gap widening in wealth occurred in the UK, with a 600% increase in wealth for the top 1% of the UK population over the same time period. And what this has meant is that our own middle class is shrinking, is experiencing tremendous financial pressure, and is in a less altruistic and generous mood at this moment. And this is going to make for a real challenge in trying to go forward, pushing in Congress, pushing in the G20 and various other places for cash dedicated to global health, or frankly to food policy, to water policy, to any of the what I call transnational threats. In addition, we are shy, Americans as individuals collectively are shy, $4.6 trillion for our personal retirements. So if it looks bad now, it's really going to look bad in about 5 to 10 years as the full baby boom generation marches off into retirement or whatever they march off into. And healthcare is the most rapidly inflating sector, not just in the United States, but all over the world in terms of cost. So that in the OECD overall, healthcare costs since 2000 have inflated 7.8% roughly a year. But here's the interesting catch. In single-payer economies, such as the social democracies of Western Europe, it inflated 16% between 2008 and 2010. So they're feeling the pinch on the home front. That is an additional pinch that's going to constrain the sense of generosity. We have a currency war going on that essentially involves countries trying to devalue their personal labor forces more than the other guy's labor force in order to attract industrial investors. This doesn't bode well for middle classes anywhere. And a liquidity crisis with roughly somewhere between 5 and 10% of the $70 trillion global wealth locked up, not out there at the moment, being in general circulation. So when you put all this together, what it means is that we have less cash in circulation. We have a shrinking middle class in most of the wealthy countries. The wealth has really shifted to the top 0.1% wealthiest in most large economies in the world. And we're shifting from a G8 world to a G20. And here comes the big catch. Most of the big G20 countries are actually still recipients, not donors, for global health. China is a major recipient of funds from the Global Fund to fight AIDS, tuberculosis, and malaria. India is a major recipient country. Brazil is still a recipient country. So when the latest G20 summit happened 2 weeks ago, if I've got memory right, 2 or 3, South Korea...
September the 22nd. Yeah.
Well, thank you very much. South Korea tried to push for... No, G20. Not,
oh, okay, G20 before that.
South Korea tried to push for a real discussion of the donor role of the G20. And the rest of the G20 nations, besides the original G8, all said, off the agenda. We're talking currency wars here. We're talking, trade and market policy. And when you really get locked down into arguments about how do we deal with global health governance and the intersection between governance and donation to support such things as all those people, the 4 million plus that we've successfully gotten on antiretroviral treatment, but need to stay on it for the rest of their lives, you cannot stop the pills from flowing. When we look at that big picture, at the level of the G20 and the emerging market countries, it all ends up being, we're not talking in the same conversation as you, because we're talking about trade policy, about technology transfer, about who controls pharmaceutical patents, and whether or not at the next pandemic we get vaccines or it all stays in the rich world. And so we don't really have a collective conversation where we're talking on the same plane when we say global health among the potential donor states, except the original traditional wealthy nations. And the original traditional wealthy nations are feeling a lot less generous today than they did 4 years ago.
Admiral Ziemer, this seems like a good place to segue towards you. I noticed on PBS you had spoken with Mr. Suarez, and you were talking about the generosity of the American people, how they're willing to be generous if they can see, in fact, that their contributions to the global health of developing countries, poorer countries, are in fact effective. And I think an important point that might get missed by some of the G20 countries is the link between prosperity, productivity, and health. And with malaria, you're talking about 450 million people, many of them children. The children die of the illness, but the adults, it doesn't make for a very vigorous or healthy workforce. So I guess the question is, against the scenario painted by, Laurie, do you believe that, the legacy of President Bush will be protected by the sort of the new dimensions we see, forming in Congress at this point?
Yeah, that's a good question, Brenda, because everyone is asking it. We have set tremendous expectations in the world today with the success of the programs. And I refer back to what Laurie said. One of the major shifts that have allowed us and the collective multilaterals in our countries to work is the increase in resources. And what we're facing now, while it's quite dramatic and causing a lot of questions, I think we need to remind ourselves that we have been at a place like this before. And so the question is, what do we do? And we don't know yet, because the dollars and the economics will become a bit clearer here over the next several months. And at that point, we have to look at the realities of what Congress appropriates, and then look at our national commitments and priorities and make appropriate adjustments. You referenced the generosity of the American people. Laurie mentioned that in a number of her comments. And I feel that's a trait that we have embedded in our DNA as citizens of this great country. And if I can get personal for a second, I have come to that conclusion based on a number of things. I grew up in Asia. My parents were missionaries. Much of their work had to do with medical missions. And in many of the countries today, 50 to 60% of health deliverables is done through NGOs, the private sector, and missions. Along with that investment comes a lot of passion and personal sacrifice, and that's going to continue. Now, that is marginal when you talk about the billions of dollars needed to sustain programs, but it still exists. And then there's also the private sector. And the private sector has been extremely committed and involved. Let me speak from malaria specifically. It's been an inclusive community, internationally as well as U.S., where we've seen the pro sports teams, nothing but nets, the soccer leagues, motivating. We maybe not have raised billions of dollars for nets, but we certainly have advocated in front of the American people the significance of engaging on a chronic international problem that we call malaria. We have had major contributions motivated and driven by Ray Chambers, the UN malaria envoy, who has mobilized private citizens as well as foundations to come together and work with governments. And then there's the donations that are being solicited through the Global Fund, the World Bank, the Booster Program, and then our own programs. So as we look to the future and we look at the commitments that we have communicated to the most endemic countries, and most of them are in sub-Saharan Africa, I think the challenge for us now is, as the budget realities become clearer, then we're going to have to make adjustments, because we have made significant progress over the last 4 years in many of the countries in malaria. The challenges that we have in malaria are much different than what the HIV and AIDS community have. We have proven effective interventions. Our program, I call it my PPP program. It's not public-private partnership, of which we have very aggressive and significant PPPs and public-private partnership. But I call it my prevention program, because 3 of the 4 interventions are all about preventing people from getting malaria. So there's a significant investment up front. As we have seen the incident rate drop as much as 50 and 60% in some countries, and all-cause child mortality dropped by 30% in 7 countries based on 2 data points. There's a lot to celebrate. So regardless of the amount of money that we get, we're going to have to rally the horses, corral the wagons, and do everything we can to sustain the progress we have made with our multilateral partners as well as the national governments, and then work towards sustaining so that when the dollar figure changes, we can continue to scale up, sustain, build capacity, and move forward.
All right, thank you.
Can I say one
Yes, sure.
It's interesting because you said at one point we've been here before. And in fact, there was a time back when John F. Kennedy was president of the United States when the U.S. Congress voted to try and eradicate malaria. And the American people set out to get rid of malaria. Not just in the United States, that we had done, the whole world. And it was, at that time, DDT was brand new, and there were no resistant insects. And chloroquine was brand new, and there were no significant resistant parasite populations. So these both worked just tremendously. And we got out there, and all over the world, the campaign went full bore, and countries that had lived with malaria at horrible levels for centuries suddenly went almost malaria-free. Jakarta went to a state of no malaria in Jakarta, Indonesia, and so on. And then Congress said, well, we gave you a deadline, and you haven't finished it yet, so the money's cut off. And boom, malaria soared everywhere, and one of the things that soared with it was both DDT and chloroquine resistance. And so the lesson I take from that, which I think is really where we need all of you on our side in this, if I can use that sort of rallying cry, is that this surge in global health interest, concern, and funding is still in an infant stage. The money's poured out, but a lot of the programs are just, you know, still making mistakes, finding their way, trying to develop the right relationships with host governments, trying to balance where does the NGO fit in, where does the faith-based group fit in, and so on and so forth. We can't, just as things are starting to work, say, oops, pull the plug because we're looking elsewhere, something else to do with our money.
Dr. Fauci, I mean, you know, we're not just talking about AIDS, tuberculosis, and malaria. I mean, most people in these countries die of the same thing that we die in this country. So the question is, how do we do it? And, you know, is there a way to do it with less resources, I guess?
You know, we each, all three of us have alluded to it in one way or another. A couple of years ago in a journal that I'm not so sure people in this room would read regularly called Nature Medicine, I wrote an article that was a commentary on the success of the programs that we've had with malaria and HIV/AIDS and to some extent tuberculosis. And the point that I made in the commentary is exactly what Laurie and with Tim and what you, Brenda, have been saying. And the catchword is really sustainable. Health is there. You don't fix health. You have to keep with it because people keep getting sick and diseases continue to emerge. So the answer to your question is that how we deal with it is true, putting more money in, but putting it in a way that it becomes sustainable within the countries that we're dealing with, and make health part of the national strategies of the countries that you are working with. I mean, it's no more. Secretary Clinton gave a wonderful speech a few weeks ago where she was talking about getting rid of the words aid to and talk about partnerships and development. And that's really, health is part of that. It's a fundamental part of that. And you know, we were talking about this panel that was here before us that was talking about the political events and foreign policy. Well, you know, health is one of the most important components of foreign diplomacy. So I think this is all part of the big picture. So the way to do it is to take an approach that we're not just going to be doing something on the short term, the way Laurie said, oh, here it is, the Congress gives us a 5-year appropriation, and that's it. It can't be that way. It has to be an enormous indefinite commitment. And not a commitment of giving, but a commitment of building sustainability.
And I think that's interesting. I referenced President Obama's speech to the the Millennium Development Summit in New York in September, and he specifically said, we should not think of development as charity, which I think we do. We think of it as something that we give. I think it would help if you, I'd be curious to know from you how building health systems, how do you build health systems in places that for so long have depended upon assistance, and can you make these trade-offs with countries to get them to do this?
We can do it, but we have to have cooperation from the country. We can train people, but they have to have an environment in their own country where it is an attraction for them to stay in their country, as opposed to training people who then go off to other countries because you've trained them. And we can't fix the economic system in a country or the attitude of a country about how much of their total gross national product they're going to put into health. We've got to partner with, and that's what really part of the Millennium Goals are. That's really part of that, is to deal with countries who are taking seriously their own contribution to what's going on in their own country. So it's not going to be easy, Brenda. It's not easy because some of the countries that have the greatest needs have leadership that don't see it that way. And it's presumptuous for us to think that we're going to go in and change the culture in countries, but we have to at least try to help train the people.
Admiral Ziemer, I mean, a lot of, when I was sort of reviewing what people were talking about, somehow these 3 pillars of development, you know, defense, diplomacy, and development, essentially. I think a lot of people think that in the past we've sort of gotten it wrong, and that so much of our resources and so much of the emphasis was on the military, and so the people bringing aid and the people bringing care were in uniforms, and it might have colored their impression of what the U.S. is doing and why it's doing. How do you sort of link aid to diplomacy in that sense?
I think that's an important point, and I would refer back to what the President himself has said, and we're anticipating his policy decision on global development, where he addresses the whole idea of sustainment, innovation, and incentivizing multi-sectoral partners, business and private. Secretary Clinton has followed up and saying, you know, we've all heard her 3D speech: defense, diplomacy, and development. And it's clear to those of us in the development business that development is a core component of diplomacy, health diplomacy, and we can talk about that all that evening. I think the Defense Department does understand their role and their mission, and they have been mobilized successfully over the last number of years to do tremendous work because of their capacity in disaster relief situations, floods, earthquake, the tsunami. I think there's an awareness, though, by the Defense Department that what they do is not long-term development. That is an industry and a sophistication that they understand needs to come in parallel to the whole of government approach to effective development. And again, one more thing. Underneath the Global Health Initiative, the principles that we see outlined, in addition to focusing on women's health, leveraging the interagency process, which includes DOD, looking for innovation, leveraging resources, but focusing in on what Tony said, it has to be owned by the country itself, so that the donors and all of the players look at one basic common plan by which we engage and can leverage what the country requirements are with the other donors. So I'm optimistic that the playing field is coming together in a clearer way, even though the finances may be a little bit fuzzier.
That's a big irony, actually, of the moment we're in. As I said, this whole, global health and development and the linkage between the two and sufficient funding to do something meaningful is a relatively new phenomenon. And we've just hit the point where we had this sort of perfect alignment of an administration, a leadership in the House, leadership in the Senate, all agreed that there had to be better coherence, that there had to be a strategy to foreign assistance, that it had to be linked in some smart way with defense, some smart way with long-term health and development. And now, that leadership on the House side is out. We'll have to see what the GOP leadership would feel about all of this. And Kerry Lugar, joint bipartisan effort, never really got beyond committee level. So we don't really know where all that's going. But one of the things, again, that I think we all took away from General Odierno's talk, which was such an inspiring conversation earlier today, was that you're not going to win over support for good governance and for working out differences between tribes, ethnic groups, political interests of various kinds in Iraq or Afghanistan if the only American presence is a combat presence. And that he also used the phrase whole of government. The whole of government approach in Afghanistan, Hillary Clinton has said over and over again, starts with recognizing that an Afghani woman has several orders of magnitude greater probability of dying in childbirth than an American woman. And very few women here probably ever had to worry, felt they really had to worry that they would die in childbirth. But if you were in Kabul or out in the rural areas, this would be a very real concern every time you got pregnant. Well, what does it mean to U.S. interests and U.S. foreign policy if more and more women in Afghanistan recognize that because of programs brought by the Global Health Initiative from the United States, fewer of them are dying in childbirth, and more of their newborns are likely to live to their 5th birthday? What does that kind of engagement mean? And I think that goes to, do you build a health system and so on, but it also just goes to, what are we trying to do as foreign policy? And why did we for so long think that all these issues, I mean, I've noticed how much of the room has left, because this is the soft stuff, right? We already had all the hard stuff.
And that's sort of, and it's a question, I'm going to pitch it to the audience after this, but I'd like to ask each of you to, answer the question, why should Americans, particularly in the current economic climate, why should, we continue to, granted, it's a very small percentage of the budget to begin with. I mean, I don't think people, some people...
Less than 2% for all of account 150.
Right. So why should Americans not, let this drop, and why should they continue to invest in development?
Well,
and healthcare, global health.
There are at least 2 reasons, probably 4, but I don't want to go on. I'll give you 2. One that I used to work on long before people got interested in global health and the globality of what we do, and that is a pure humanitarian reason. As human beings, we should feel a moral responsibility, if it is possible, to help to take care of people who are less fortunate. And I think as human beings in general, and particularly as Americans, that has been the spirit of America for a very, very long time, maybe ever since the beginning of our nation. That's one reason. The other reason is that we live in a global community, and we are all interconnected economically, politically, from a security standpoint. And a healthy world is a world that will be economically viable, and we depend on different countries back and forth. We know that. That's an economic discussion that can go on, but also from a security standpoint. And I would venture that if Afghanistan were not as poor a country as it has been from the standpoint of health alone, it's one of the most unhealthy countries in the world, I'm not so sure that we would have had Al-Qaeda being able to just go in there and roam freely if that was a strong, healthy nation. So it goes everything from humanitarian to economic interest to pure security.
I would go another level, just add on to what Tony said, all of which, of course, I agree with. As long as folks in Gaza and the West Bank have children contract measles, and Israel goes decades without ever seeing a case of active live measles inside Israel, you're not going to have warmth between those 2 places. If the odds of a Palestinian child living to age 10 are exponentially lower than the odds of an Israeli child living to age 10, you're not going to reconcile the differences between the 2 places. Expand that globally. We have, we had this clarion call a year and a half ago when H1N1 swine flu emerged first in the U.S. and then explosively in Mexico. And fortunately, it was a relatively benign virus, not anything akin to the 1918 horror of influenza. But everything that we had always warned would happen in a pandemic that would aggravate tensions between nations and misunderstandings between nations really did happen. Overwhelmingly, the very slow and eventually available vaccine concentrated in the wealthy countries. Overwhelmingly, the only effective drug, Tamiflu, concentrated in stockpiles in the wealthy countries. And overwhelmingly, every single thing in the toolkit that could address the pandemic was far more available in a very rich country than anywhere else in the world. In fact, by the time most of the vaccine supply for Africa reached Africa, the epidemic was over. So what that said is to the rest of the world is, you know what? Why should we partner with you on anything? Because when the really big one comes, you're going to walk away from us. You're going to hoard everything. You're only going to take care of your own. If we can't demonstrate that we think the health and survival of a baby boy in Beirut is as valuable as a baby boy in Los Angeles, we're never going to have an equal conversation.
And
Help is the
Admiral.
right thing to do. And as Tony has said, and Laura, the programs that the U.S. government are investing in are saving a lot of lives. PEPFAR and malaria were invested as a life-saving mechanism, but now we're seeing that it's building capacity and sustainment. In addition to health, the United States government is spending one of the presidential initiatives is Feed the Future. So in addition to health, we have nutrition and food to move towards this whole development commitment. And I'll jump back to what Tony said earlier, the Millennium Development Goals. You hear a lot of chatter about that. But getting back to malaria, we address 6, which is reduction in infectious disease. We address the maternal health issue and child survival. But healthy communities mean kids in school, so we're touching education. In Malawi, a mother making less than $1 a day spends 30% of her disposable income on anti-malarial drugs. That's poverty in action. If we can eliminate that from her discretionary income hit, that will help her that day and that moment. And so that then drives us to Millennium Development Goal, poverty alleviation. So while we do excellent work in health, where we are saving lives, the United States government can actually show impact and show the data that this is a good return on investment. And it drives us back to the ultimate goal of poverty alleviation, community development, which is what we're all seeking and hope for.
If there are questions, certainly we can start here. Yeah, all right. Oh, I didn't, okay.
Can you hear me?
Yes.
Oh, I'm Patricia Kraske from the Western Mass Council, World Affairs. I know it's not a very economic consideration or a militarily important country, but for purely humanitarian reasons. Shouldn't we be doing more about Haiti, which is a country in our own hemisphere? I'm very concerned about the recent outbreak of cholera and the fact that what I read about that we had helped initially and then we pulled back. And what I would like to know from you folks, is there any kind of ongoing help in our own hemisphere for countries, especially like Haiti, who have nothing really to offer to us economically, militarily, but from a humanitarian point of view? Thank you.
Haiti, in last spring, Captain Mendoza from the U.S. Navy and I co-authored a piece saying the National Weather Service was forecasting 16 major tropical storm events would hit the Caribbean with a reasonable odds that at least one of them would slam Haiti. Didn't we need to immediately, as a matter of urgency for the survival of the people of Port-au-Prince, build some structures that could withstand storm and flood conditions, to which the people living in tents could flee, build an early warning and radar system, which they didn't have for distinct local weather detection, build an emergency alarm system with warning and training of the populace so they knew where to run. And now Hurricane Thomas has hit Haiti and none of that is in place. And people are literally holding little pieces of plastic over their heads while the rain and wind are pouring down upon them. And we saw similarly with cholera, it's axiomatic as we go into a far more globalized, which is good news, humanitarian and peacekeeping response in the world, that the humanitarian responders and peacekeepers themselves can become vehicles for microbial hitchhikers from all over the world. If you're moving UN soldiers, they're in Congo one week and the next week Nepal and the next week somewhere else, and the Red Cross workers are the same and the MSF are the same, you have the potential for every single one of them to be a disease carrier. We know the cholera was introduced from outside. It certainly didn't naturally arise spontaneously out of the water of Haiti. And it doesn't really matter. I don't want to blame anybody for that introduction, but I think that our inability to respond very effectively and very rapidly once it did emerge and keep it very localized is disappointing.
I think the initial response, and perhaps Dr. Fauci could address it, was to dealing with people who were severely injured or, facing major trauma. And until, that was the initial concern. The question of why we have not been able to rebuild Haiti or get around to doing that sooner. I think the bulldozers didn't get there until October. I know this is not exactly health per se, Dr. Fauci, but did you have
No,
some?
it
is in a sense, yes.
It encompasses health. It isn't fundamentally health. It's really a commitment problem to our neighbors about doing something about getting that country to be self-sustainable. If you look at some of the heroes of the health areas in Haiti, people like Bill Popp from Guesquio and Paul Farmer, who spent so many years there, it is clear that you can accomplish an extraordinary amount with actually relatively little investment. It isn't as if you're going to be putting billions and billions of dollars in there. You could probably do it. So the answer to your question, the shorter answer is we should be doing more.
Because they're in our hemisphere.
Well, but there's...
and for humanitarian reasons.
I think humanitarian reasons also, and also because, the whole issue with cholera, if you look at them, again, just very briefly, if you look at the cholera map, the belt of cholera occurs in regions. So to think it's going to stay, as Laurie said, in Haiti, once you introduce it into a region and people go back and forth to different countries, you're being presumptuous and naive to think that it's guaranteed it's going to die out there. It likely will, and I hope it will, but may not.
In fact, just historically, the greatest cholera outbreaks in the United States were all related to the slave trade and the movements into the Caribbean and back up again. And so we constantly had cholera reintroduced into our waters, especially in New York City, sometimes with devastating results.
I appreciate your interest in Haiti, and just to address the what are we doing right now with the storm and the cholera outbreak. If you go to the USAID website, you'll see that there are 20 members of a disaster response team that's there right now. And there's a significant, aggressive amount of work going on in conjunction with the Pan American Health Organization, CDC, and USAID. So just for the immediate update, I would invite you to go to the USAID website, and that'll give you at least today's readout.
Thank you.
Next question. I'm sorry, over there. Sorry.
My question is on HIV in sub-Saharan Africa. I'm Chuck Womack from the Tennessee World Affairs Council, and my question is, what funding for the U.S. government and the NGOs and other governments is available for prevention right now in sub-Saharan Africa for HIV? And what would it take, how much funding would it take to have a sustainable preventable program for HIV in sub-Saharan Africa?
Okay. Well, when we put together the original PEPFAR program, 20% of the total amount was in prevention, 55% in therapy, and the rest in care, between 20 and 30% in prevention. What would it take, and that's just the PEPFAR program, there are other components of it for prevention. It really would require access to the modalities of prevention that we know work, and that's the point that I made that is so frustrating. Even under the best of circumstances, when you have health infrastructures that don't allow any more than 20% of the population who would clearly benefit from a proven prevention modality don't have access to it, that's a very serious problem right there. So it's the whole issue of what all four of us were talking about building sustainable health systems, because if you don't have a health system, you're not going to get anybody into the system to be able to counsel them or to give them the care about what they need to do to prevent. That's the structural, functional answer. But there's also another answer, that when you're dealing with a sexually transmitted disease in cultures in which you have flagrant and egregious disenfranchisement of women, in which they really don't have the human rights to be able to protect themselves in a society that really demeans women, that becomes very difficult. And we, as my friends in Africa tell me all the time, and it a smile to my lips, you don't want a white guy like me going into Africa and saying you have to treat your women better. What you have to have is the leadership in the African countries realize that they have to turn around centuries of cultural issues which have not allowed their population, particularly the women, to be able to protect themselves. That's one of the really important stumbling blocks in prevention.
And stigmatization and
of course,
homophobia even in this country, hostility towards gays, has contributed to a resurgence in certain communities, among gay communities here, of HIV.
Right.
So we haven't managed to get, we haven't managed to get it under control and make prevention effective here. I mean, I think this administration is focused, zeroed in on certain groups. We have time for 2 more questions, and then we'll have to wrap
I wanted
up.
to shift to another topic. As I recall, with the H1N1, we did not have enough vaccine even for here. And it got into the whole complex of vaccine production and which companies are going to do it and how much lead time do you have in knowing exactly what virus you're dealing with, and then distribution. So I wondered if you would address that part of the problem.
I'm going to give that to Tony.
Well, the problem with not having enough vaccine for influenza is that we have, the root cause of that really is that we as a nation and the world has not taken seasonal influenza very seriously. We say, well, I have the flu and whatever. And then when you think about a pandemic, you get all nervous. But seasonal influenza is a very serious issue. It kills at an average of about 36,000 Americans a year, with 200,000 excess hospitalizations. About 500,000 people a year die of influenza. But we just take it in stride. The incentive to make a vaccine that, in a way that you can quickly ramp it up and get it in a matter of a couple of months, and I'll take it one step further, the incentive to make a universal vaccine that you don't need to change from season to season, that you can give it once every several years and protect not only against drifted strains, but against strains that actually change dramatically as the pandemic strains. We haven't had that incentive on the part of industry or on the part of our leadership to encourage industry to do that. The good news about